Hi everyone, welcome to our webinar Eating Disorders this evening. My name is Helene, I'm from West Vic PHN, and myself and Jade and Joe from our organisation will be running it. I'd like to begin by acknowledging the traditional owners of the land on which we meet today. I'd also like to pay my respects to elders past and present. So yes, welcome everybody and thank you very much for attending. Just a few little things about our PHN. The majority of our webinar events are recorded and freely available on our PH Learn YouTube channel. We do have a practice communique that we send out to all practices fortnightly. So make sure you all have a look at that. It's got our external calendar events and internal. For this evening's meeting, participants attending will be put on mute for the course of the meeting. Should you have any questions, please type them in the question box and I will ask them on your behalf at 8 o'clock after the first presentation from Eating Disorders Victoria. They'll all be answered anonymously, so please feel free to type those in. Our presenters for this evening are Rebecca Lister and Jenny Conaway from Eating Disorders Victoria, and we have Holly Labour from Bowen Health and Russell Golden from the Geelong Clinic, who will give an overview of local services and referral pathways. Please make note of the West Vic PHN health pathways relating to this.
Hi Helene, you cut out before. Just checking it's okay to start. Thank you. Hi everyone, I'm Jo Rose and I'm the Health Pathways Programme Officer at Western Victoria Primary Health Network. I'm going to provide a brief introduction to the Eating Disorder Health Pathway. For those unfamiliar with Health Pathways is an online clinical platform designed to support primary care clinicians. It contains many locally agreed condition-based guidelines and local referral information. Pathways are written by clinical editors in collaboration with specialists, subject matter experts, peak bodies and agencies according to best evidence and in consideration of the local context. You'll see on the slide a sample of pathways relevant to this evening's content. Health Pathways Western Victoria have completed a large amount of work on eating disorders and mental health presentations and management in primary care throughout 2020. Health Pathways Western Victoria now has approximately 850 clinical, referral and resource pathways available. The Western Victoria Health Pathways team has also developed the first national primary care pathways for COVID-19 and have worked closely with federal and state level clinical experts in the development of the national COVID-19 vaccination guidance for primary care. So please do also make use of this comprehensive resource. The Health Pathways content is only available to clinicians in Western Victoria and the login details are available in the Health Pathways handout, and I'll also add them to the chat thread shortly. If you have any questions regarding Health Pathways, please feel free to email us at healthpathways@westvicphn.com.au. I'll now hand over to Rebecca and thank you for your time.
Good evening, thank you so much for joining us. My name's Rebecca Lister. I'm the Director of Strategic Programs at Eating Disorders Victoria, and tonight I'm working with Dr. Jenny Conaway, who's an expert in eating disorders. It's a great pleasure to be invited along to the Western Victoria PHN to speak with you tonight. So our topic tonight is eating disorders, early intervention and community treatment. You don't need to take notes tonight. We'll send you a PDF of the slides, but of course, if you do want to take notes, please feel free to do so. If there's questions, put them in the question box as we go along, and hopefully we'll get a chance to answer your questions as we proceed. Again, thanks to Western Vic Primary Health Network. Eating Disorders Victoria, we've been around for almost 40 years. We're a community-based organisation, but we're a statewide organisation. We work under 4 principles of perseverance, connection, courage and optimism, and we're the primary source of support, information, education and advocacy for people with eating disorders and their families. We have an enormous amount of information on our website, and we really urge you to go to our website to have a look at the wide range of resources that we have, particularly for GPs. We have dedicated information for GPs on our website. I've also listed another website there, which is called How Far Is Too Far, which is a really, really easy website to navigate for both yourself and potentially for your patients or clients. Eating Disorders Victoria, we have a wide range of services. I'm not going to read through all of those to you tonight. It would be far too tedious to do that. But just a couple of programs that I want to make aware to you. Our EDV Hub, which is our phone and web and drop-in service. Anytime you have an inquiry or a query about eating disorders, please contact the Hub. We really urge you to make contact with us. We have a telehealth nurse who can support you with navigating the treatment system and to assist you to find care coordination for people with eating disorders. We also have a wellbeing program which was established during COVID to really support patients and clients prior to them getting formal therapeutic treatment. So again, if you need any information, please make contact with us. And of course, you'll see down the bottom, we have a mental health and dietetics clinic. So our clinic works both face-to-face and in a telehealth setting. Our learning objectives for tonight are to evaluate the signs and symptoms of different types of eating disorders, to demonstrate the role of the GP with initial appointment and medical monitoring, to talk to you about some of the screening tools that we use, HEAD-SCOFF and the EDEQ, and some of those you may already be familiar with, how to navigate Medicare and the changes that that have happened with Medicare in the last 12 to 18 months, and how to assess the clinical risks associated with eating disorders. I'll now hand over to Jenny, who's going to take you through all of your learning outcomes this evening. Over to you, Jenny.
Okay, thanks very much, Rebecca, and thanks to Western Vic PHN for the opportunity to hopefully rally some enthusiasm out there in general practice land, particularly in regional Victoria, to not be frightened of stepping up and helping your patients with eating disorders. Just a quick bit about my background. I work in regional Victoria, plus do some specialised work down in the city, specifically around eating disorder management, and also working very closely with a lot of the tertiary services and the private services such as Geelong Clinic and the Melbourne Clinic as well for the more serious end of the spectrum. So I guess to kick off, we need to really understand what normal eating is. And again, as Rebecca said, we've got a lot of information to get through, so I'm not going to read slavishly through all of this. But I guess to get an idea of what normal eating is, you eat when you're hungry, you know when you're full, you can choose the foods you like, you don't spend hours ruminating about what you're going to eat, and then if you do eat something, you don't then feel guilty or ashamed or, you know, work out ways of offsetting the fact that you've eaten something. The key here is flexibility, and often people who have an eating disorder, which we'll go into in the next slide, you know, they are incredibly rigid. So disordered eating is a continuum, really. People don't usually wake up one morning and have developed an eating disorder overnight. You know, something leads into the eating disorder, and we talk about disordered eating. So that often can manifest as unhealthy eating patterns. It might be people who decide they're going to cut out major food groups. It might be that they start skipping. It might be that they are compulsively eating. And the key here is that it can start to impact on their emotional, social and physical well-being. And it is very much a risk factor for going on to develop an eating disorder. So that leads us to the key topic of tonight: what are actually eating disorders? They're actually very serious mental illnesses, and they also have serious physical sequelae. And they're characterised by eating disorder, you know, deranged eating, exercise, often to major excess, and body weight or shape becoming very much a preoccupation to the point where it actually impacts on their ability to function. And it is, as I said, a psychiatric and physical illness. They're relatively common. In fact, you know, I often quote when I'm speaking to say that it's as common as asthma. And when you think about how much funding is spent on asthma and other chronic illnesses, it's only been recently where the government, thankfully, has started recognising and appropriately funding support for people with eating disorders. The rates are increasing. There's been an explosion during COVID. All the services that were already pretty tightly stretched have been overrun. And it's very important for us out in general practice to be able to pick up the cues and hopefully nip things in the bud before they progress to the point where people are needing more intense support. Anorexia, AN, is, they estimate that the rates are about 1.5%. BN is bulimia nervosa, 2.1. Binge eating disorder is the most common. And OSFED is one of the other new terms that have come out in the DSM-5. And look, if you want to read more into some of the more obscure forms, well then please feel free. We're going to be focusing on the big ticket ones though tonight. The other big thing with anorexia nervosa is that it has the highest risk of premature death of all the psych illnesses. It has a very high rate of suicide because of the chronicity and the impact it has on the person's life. And between the medical complications they can develop and the psychiatric aspects of it, they often do die very early compared to their peer matched groups. Okay, well, 15% of females will experience an eating disorder at some point in their life, which is fairly horrific. And it's the third most common chronic illness in young women. And an important fact to bear in mind is it's not just females that suffer with eating disorders. 1 in 4 actually are male. And that's a very important thing to bear in mind. And there are often comorbidities associated with it. Often there'll be pre-existing anxiety disorders, there'll be social anxiety, often OCD comes to the fore, personality disorders, particularly the borderline personality or the chronic PTSD is the okay term we use these days. And the other group are people on the spectrum. We know that there is quite a correlation between people with ASD who seem to develop are at increased risk of developing eating disorders. The other end of the spectrum, I guess, is people with chronic illnesses such as diabetes who are overweight and who might have bowel issues. And so they are, cutting out different food groups. They might be doing elimination diets. They might be wanting to lose weight. And, those people actually are more at risk as well. All right, well, I sort of covered this before. We've got the anorexics, bulimia nervosa, binge eating disorder, ARFID, avoidant restricted food intake, other specified feeding or eating disorder, which is a bit like the old irritable bowel syndrome. We're not quite sure. We just, put them all in together. The unspecified feeding eating disorder, and pica and rumination. And again, if you want to look that up further, please feel free. So just quickly whizzing through what constitutes the diagnosis of anorexia nervosa, there is a definite restriction of energy intake which leads to significantly low body weight, this incredibly intense fear of gaining weight or becoming fat, a major disturbance in their body image. And, you sometimes see in the media these anorexic patients who are basic walking skeletons, but when they look in the mirror, if they can look in the mirror, they see someone who's overweight. And then the subtypes are the restricting type that basically are starving themselves. And then you've got the binge eating purge cycle types as well. Then it leads us on to bulimia. So you'll have people who recurrently will binge eat. They absolutely have no off switch, and they will then feel quite out of control. And then they feel incredible guilt and shame and will then undertake these inappropriate compensatory behaviours. Purging, which typically can be self-induced vomiting or laxative abuse, often to incredibly high levels. And they also have a very strong emphasis on their body weight and shape in how they see their self-worth. And then binge eating disorder, which actually is one of the most common that we see in general practice. And if you ask the right questions, you'll be unpleasantly surprised how many of our patients actually suffer with that. So it's recurrent episodes of binging where they are eating far more than your average person would, and they have no control. But these people don't actually then go on to do the compensatory behaviours. They eat more quickly, they eat until they feel very full, they eat when they're not hungry, they eat alone, and they often have a great sense of shame and guilt and disgust with themselves. And they become very, very distressed in the process of doing it and very much hate themselves, but feel that they can't control it. So that leads us to, how can you tell if someone's just overeating or binge eating? And on that, we often think about, well, at Christmas time, a lot of us are guilty of overeating. We have all the lovely Christmas foods and we eat a bit too much, and then we sit there feeling very bloated and unwell. But we recognise that and then don't usually feel horribly guilty and disgusted with ourselves. Whereas someone who binge eats, this is often a daily occurrence, sometimes in the very severe cases, but by definition, if it's happening more than 3 times a week, then that is considered binge eating. And, they really do hate themselves for the fact that they do it. Okay, now getting down into some of the less frequent presentations, which are really just sort of, without going into too much detail, these are people that don't tick all the diagnostic criteria for the DSM-5. So these people lose weight, but they may not be as cachectic as the anorexics. They basically are avoiding particular food groups, and it does actually impact on their psychosocial functioning as well. But it's not quite the same picture as we see with the anorexics. And this is often tertiary hospital service diagnosis when you're getting down to this sort of fine detail. Okay, and then we've got the grab bag of the other specified feeding and eating disorders. So atypical anorexia often are people who actually aren't underweight. You know, they may have started off overweight and they've done well with their dieting, but, you know, in the process of losing the weight for whatever reason, they actually develop anorexic thoughts. Subthreshold bulimia nervosa, they're doing all the activities, but it's not quite at the frequency that gets them over the line to have a full diagnosis of bulimia. Same with the binge eating. Purging, these are the people who are, you know, either abusing laxatives or making themselves sick. And then night eating disorder, which is actually reasonably common too, if you ask about it. These are the people that, you know, they eat normally during the day, but then they find that they're getting up and raiding the fridge overnight. I often say to patients it's the Nigella Lawson disorder, because she often would be, you know, going to the fridge in the night and eating her leftover chocolate cake. And then the unspecified feeding or eating disorder. So again, this is they're not fully ticking all the boxes for the full diagnosis. So we might perhaps skip through, I'm trying to remember what the next slide is. Oh, and pica and rumination. So this one, pica is, you may remember from, you know, student days learning about this, is where people eat things that actually have no nutritional value. So they eat their hair, they'll, you know, eat little stones, they'll eat anything and everything. Very, very unusual. You don't see it all that often, but it's often worth asking about if you've got someone who's coming in and divulging about that they have concerns. And rumination, this is something we often see with the people that make themselves sick a lot. You know, their gastroesophageal valve doesn't work very well anymore because it's been abused so much with the vomiting. And so they can actually, you know, when they've eaten something, they can bring it back up, re-chew it, swallow it again, and go over and over again. Sometimes they spit it out, but it's almost like chewing the cud. And it then stops them actually wanting to eat anything further. These people often have, you know, all sorts of GORD symptoms as well, and you know, sometimes we'll see this in the young ones that have got anorexia or bulimia. Okay, so what makes a person vulnerable for developing an eating disorder? Well, the bad news is that there's no single or easy identifiable cause. It's the old biopsychosocial blend along with external factors. I was at a talk once where they said that your genetics, and there are actually genetics as part of this, it loads the gun and stresses pull the trigger. And that's something often we see. So getting on to the genetic or familial factors, it does appear that having a first generation biological relative, parent or a sibling with an eating disorder makes you more vulnerable. And also the personality traits. So perfectionism is a big one. Black and white thinking is another big one. You know, I often say to my patients that we've diagnosed with anorexia is they're often very high achievers. They are their own worst enemy. They have extremely high expectations on themselves. And in adolescence, we find that at times of transition is a very vulnerable time. So we see peaks at that transition around puberty, and then also going into latter secondary school where they're doing their VCE, and the stress of that and the expectations they put on themselves, but also family sometimes, can actually trigger an eating disorder to develop. The other time too is that, you know, other times of transition, particularly for women, so we see sometimes, which is not thought of often, but around the perimenopause, can be a time when women can be vulnerable. Also with pregnancy and childbirth and breastfeeding, with the major body changes that happen and the hormonal changes, we often do have women who develop eating disorders. So it's really important for those of us working in general practice from cradle to grave care, which a lot of people in the country do, is that they're, you know, just think of this and maybe ask the question at different times when people are coming in, because you might be surprised about, you know, the answer that you get. Okay, so what's the raft of psychological factors that can set a person up for being vulnerable to an eating disorder? Basically just about anything. So low self-esteem, mixed anxiety, depression. If they haven't got adequate coping skills for whatever reason, we've mentioned perfectionism and having a bit of an OCD type personality. If they're impulsive, if they're super competitive, we see that sometimes a group of people that I haven't specifically mentioned, but certain sports, so where body shape is a big impact. So, kids that do gymnastics or calisthenics or athletics, or you've got the kids that are doing rep sport, particularly with footy and basketball. For the boys, that emphasis on muscle mass and not much body fat can become very problematic for them. The black and white thinking I've mentioned. People who internalise their emotions, they turn it inwards on themselves, the ones with the high personal expectations as mentioned, and also people that have that high need for approval from others. And, we sometimes see, and we'll talk to this a little bit more, in families where there is a lot of commentary about, how you look and what you're eating and so forth, that, if that's the sort of language that's used in the family situation, that can sometimes have quite a big impact on kids and young people. The other big thing from a socio-cultural perspective is the social media and general media, particularly the impact of that on young people. So they're really unrealistic expectations that young people have when they look at what's on Instagram and with, the pop culture, and equating that being beautiful and being good and having self-worth is very much tied up in your appearance. So you have to look a certain way. You have to have that ripped AFL footy player look. You have to look like the Instagram influencers, and that whole idea of striving for perfection, which, you think about it, most of these photos are photoshopped anyway. So trying to, educate kids in that regard is something I know is a push that's happening in the schools. Thinking that you're worth more depending on how beautiful you are rather than what your inequalities are. And as I mentioned earlier, professions where there's an emphasis on body size and shape. So your dancers, your professional sports people, jockeys are a big group. And then finally, marketing strategies. The PR people have got a lot to answer for, the advertising industry. So the external factors, one of the main risks for developing an eating disorder is actually going on a diet. And it's actually quite scary hearing from school kids how many of them are on diets. And, if you don't diet, it's very unlikely that you will develop an eating disorder because, the dieting can become quite competitive and leading on to these major life events and change. A key time I've found that I have to be quite concerned about the various schools that I look after is, and it's very old-fashioned, but debutante ball time. The girls are all wanting to look gorgeous and fabulous in their deb dresses, and I'm sure some of you practice in areas where the deb ball is still a thing. And, end of year school social, graduation ball for the BCE kids, all those sorts of things, as well as, a bit later on, coming up to the wedding, wanting to look fabulous for the, social media photos of the Insta-worthy wedding day. These sorts of things, like people can lose control over their wish to pull a few kilos off. Then you've got, trauma. That's a huge one. And we know, particularly what's going on at the moment with, more and more women talking out how many have been subject to horrendous things and have not felt that they can speak out. And that trauma, when it's buried, it's phenomenal how often an eating disorder will be triggered by some sort of event like a sexual assault or sexual harassment. And it's a protective mechanism, particularly with binge eating. We're finding that a lot of people will actually comfort eat to soothe themselves, and then they lose control of that. So, for all those people that you're looking after that have got trauma and PTSD, it's often worth having a conversation about if they have any concerns about how they're eating and their appetite. And then we've sort of spoken a bit about the peer pressure and influences. And also, within the trauma, I guess, if you've got people that have been bullied or teased when they were younger, again, it can sometimes be a self-soothing thing to overeat, comfort eat, and then, it gets away from them. Okay, so onto some protective factors now. So people who have sort of an innate sense of self and sense of self-worth and aren't reliant on external validation seem to be able to resist and be less at risk. If they've got a positive body image, this healthy at any size movement that is thankfully becoming more and more prevalent in society, being aware that a lot of the stuff you see in the media and on social media particularly is fake, and understanding that, the expectations that a lot of people put on themselves are quite unrealistic. Being emotionally well and having good social connection, be it their good solid peer group, that they're well engaged, they might have activities outside of school that they engage in that gives them a positive sense of self-worth. And those that have got good coping skills and problem solving as well, which, if you read that list, you'd hope that, we're all raising kids to have all those attributes. But unfortunately, there's lots of kids out there that don't, and they grow into young adults who then really struggle, and so, are going to be more at risk. Okay, so family does have a bit to do with it. It's not the be all and end all, but families can actually have a role to play. And so the whole modelling healthy eating and regular physical activity from a young age with the kids, and certainly into teenage years, is very important. Try to have everyone sitting down at the table together to eat regularly is very important too. We often find with the younger teenagers, they start withdrawing and not wanting to eat with the family, and they want to eat in their room. And if they're all the sorts of things, and we'll talk more about this later, that can maybe be warning signs that things are going astray. And this language used around appearance and not overemphasising weight and appearance. Unfortunately, some families are very body centric in how they talk to each other and will make sort of offhand comments. And, for most people that just goes over their head and they don't take it to heart. But every so often there'll be a kid, and, I've had kids as young as 8 and 9 who, something's been said, they might have a bit of puppy fat or something, and some relative has said something and it's cut them to the core, and then all of a sudden they're starting to, I'm not eating this, I'm not eating that, and they actually become quite ill. So I guess try to educate families around that. And then I guess in an ideal world, what could we do? Wave the magic wand to try and improve how society deals with all of this. Acceptance of a wide range of body shapes and size, and that's where that healthy at any size movement has come from. And also like that this girl can as well, having activities so everyone can be included, and so you don't feel like you have to be a size 8 and in your lycra to actually go and do some exercise, because that can be very confronting for people trying to get them to, if they are overweight, to get them to engage, as I'm sure all of you are aware. Trying to influence industry not to place such emphasis on weight and appearance, but really I don't know how much influence we have on that sphere. And then also I guess in schools, trying to, as part of their health and human development and wellbeing programs and so forth, trying to take some of the emphasis that it's not just about how you look, but as we all know, in adolescence, unfortunately, it still is very much how you look. Okay. All right, now, where do we come in with the early recognition? So basically, being what we're hoping people will take on board from today is that they'll, be aware now at the end of the presentation and with your further reading, what some of the warning signs can be they physical, psychological, behavioural, being able to establish rapport and have effective communication. Now, for those of us who have, been in our practices for a while, you're not necessarily seeing brand new patients. It might be people that you'll go away from tonight, think, oh, maybe that's something I've missed with whoever, and you'll be able to perhaps open up the conversation with them and feel confident that you're doing it in an appropriate and sensitive way. And then finally, we'll cover some of the screening tools as well. So we've kind of spoken to this. The high-risk groups, your teenagers, women during key transition periods, women with diabetes or PCOS, you know, we've all got these patients that come in and, you know, they're carrying a bit of weight and they're wanting some support with that. Or the ones that come in and say, oh, I've got something, you know, some event coming up, can you give me some diet pills, you know, Duramine, because, you know, some doctors still prescribe that. We've spoken about the athletes, we've spoken about family history of eating disorders, and then generally people seeking help for weight loss. And a group I find is those folk that are actually, you know, they might be due to go in and have a hip or knee operation. And the surgeon said, well, I'm not going to touch you until you lose 10, 15, 20 kilos, whatever it might be. And these people actually at great risk because they're in pain and they want their operation. And so they will go hell for leather in losing weight. And sometimes some of them will tip over into developing an eating disorder. So it's just very important. And I don't know, you know, down in your neck of the woods, but some of the surgeons that work in Eastern Health, which is where I predominantly practice, you know, they don't have, some of them don't have very good interpersonal skills, and they will say things to patients that are actually really quite rude, and people take it to heart because the surgeon has said it, and then they sort of go overboard and can sometimes actually develop really unhealthy eating patterns. All right, so sometimes it's not the patient coming in telling you what's going on. It'll be a concerned family member. And having worked in rural general practice for virtually all of my, more than I care to admit, years as a GP, families are key. And you will often have a parent or a sibling or even sometimes a grandmother coming in voicing concern about their loved one. And, you know, those of you that are working in rural towns, you probably look after the whole family. It's something, you know, that often happens in country areas. So using those family or significant others as a source of information can be very, very helpful, and often will be the first alert that you get that something might be going on. And we've got, you know, sometimes the hints can be from the patient that they'll make some sort of, I don't know, very negative comment about themselves in an offhand way, or they might come in and, you know, I was just trying to think of the most recent ones. I had a woman come in and she was saying how she was wanting to be sent off to get some tests because her husband had told her that she was, you know, getting fat and he didn't like it. And, you know, she wasn't getting fat. She'd had a baby and she hadn't quite got her, you know, baby fat off. So it was physiological. There was nothing actually wrong with it. And, you know, that sort of thing. And she actually, when I questioned her a little bit more, she got very upset and broke down, and that opened a whole can of worms. So the 15-minute consult became a half an hour consult with a long consult for follow-up. Physical things. Okay, so how many of you have got people who complain of tiredness or dizziness or tummy bloating, or their periods are going funny, or, you know, young people coming in because they keep pulling muscles or rolling ankles, or, you know, these sorts of things can sometimes be indicators that there's an eating disorder lurking in the background that are causing all these physical symptoms and manifestations. The psychological side of things, I mean, that can be very varied. You have people who get very anxious, you know, that they come in and say, oh, look, I think there's something wrong. I just don't want to go out with my friends. I just, you know, I've developed like a social anxiety, or those that, you know, look up Dr. Google. I've had people come in saying, I think I've got agoraphobia because they don't want to go out anywhere. And, you know, it can sometimes be, well, they don't want to go out because they're too frightened to eat in front of other people. And so their social world just contracts more and more. And then the behavioural thing, well, this is, you know, the young ones coming in and they're complaining of heartburn and reflux. Well, why would you have reflux? It was because they're sticking their finger down their throat and making themselves sick several times a day. And obviously that's causing gastric reflux. Or, oh, my tummy is, you know, I can't eat this, that and the other. It gives me terrible bloating and I must have celiac disease. Or, you know, oh, I've got constipation. Can you give me some laxatives, please? Because the ones from the chemist or the supermarket aren't working. So, it's, you know, these sorts of presentations that we see on a weekly basis, you know, can sometimes be a hint that there's something else going on. And I guess the thing is that and we all, we all listen to our patients, but I guess just to be clued in that sometimes they are throwing you hints because they're often very embarrassed about what's going on, and they don't feel that they can come in and say, oh, I'm worried about, I might have an eating disorder. That very rarely happens. And so it's more that they're throwing you a few little crumbs, hoping that you'll pick up on it. And as the regular family doctor who they trust, we are very well positioned to actually then engage with them and ask them a few questions. And also then often it's a huge relief for them because, they'll think, oh, thank goodness this doctor actually realises something's not right. And then they can start telling you more about what's going on for them. Okay, so the things to look out for are rapid or sudden weight loss, particularly in younger people. The frequent changes in weight. Now, these are the yo-yo dieters. So how many of us have got these? People, they're overweight, they diet, they lose the weight, then they put the weight back on, and then, back and forth and back and forth. And, in the middle of that, often they get gallstones as well because of these, major metabolic shifts that are going on. The irregular or absent periods, dizziness, constant fatigue, the skin and hair changes. Often we get people coming in saying, oh, maybe, you're tired and you've noticed that your hair and skin is changing. Oh, we better check your thyroid. So how often do we check for hypothyroidism in that scenario? When in actual fact, it may well be that they're just not eating adequately and they're nutritionally deficit. The sensitivity to the cold, particularly the ones that have lost a lot of weight, often, on warm days, they'll come in and they seem to be rugged up like they're going to Antarctica, when in actual fact it's because they just lose their thermal regulation and often have, cyanosis, peripheral cyanosis. And the signs of frequent vomiting, that's, I don't know how many of you have actually checked for this, but there's actually a sign when people are making themselves sick. They get calluses on their knuckles because they're so much. And lanugo, that's, again, when you've got women in particular where their ovaries have shut down and they lose all their, a lot of their secondary sexual characteristics, and they'll actually revert to developing that lanugo, that very fine hair on the face that often prem babies have. So you would hope that you'd pick signs up before it got to that stage, though. Okay. We've spoken about the gastrointestinal disturbances. You often have people coming in saying, oh, I've got, I must be celiac, or I might have FODMAP, because people know about FODMAP now. If they have been really restricting in their protein levels, have low albumin, often they could develop edema. Bradycardia is a very significant symptom, and we'll talk about that, a sign rather, and we'll talk about that a bit more. The hypotension and also postural changes, along with hypothermia, and a dehydration for those that are really restricting or using laxatives, and just reduced cognitive capacity. I mean, we often see people become very emotionally labile, and so they don't have that emotional regulation, often because they're hypoglycemic most of the time if they're restricting or over-exercising. But the other thing that we find, and this is something with the VCE students I see a lot, that they just can't study effectively, and so they're the kids that their grades have been going along often very, very well, often at the top of their class, and then all of a sudden their grades start to drop, and it's like they have to read something, they can't retain things, they get all addled and confused. And I look after a lot of country kids that come down to and are living in the college halls of residence at Melbourne Uni. And eating disorders are rife there, I'm afraid to say, and a lot of those kids really struggle with their assignments and getting their shoots work done on time. Now, the psychological warning signs, we've covered a lot of this. So negative body image, they really don't like themselves, they have low self-esteem, very rigid thinking. The lack of control. Control is a huge aspect for people with eating disorders. The anorexics, often they feel that everything swirling around them is out of control, but what they can control is what they're eating and how much exercise they're doing. Whereas conversely, often the binge eating people have no control. They don't have an off button or an off switch, and when they start binging, they cannot stop. They will just eat enormous amounts and then beat themselves up afterwards. The fear of gaining weight is a huge thing as well. Oh, sorry, we've moved on to the next one. Okay, so we've spoken a bit about the irritability and the changes in mood, the heightened anxiety around meal times. You know, for people with anorexia in particular, you know, they start winding up as soon as they wake up about what will I eat, what can I eat, you know, counting calories, weighing portions. If I eat this, then I can't have that. If I have that, then I have to go for a 20K run, or I have to do 100 push-ups, or whatever it happens to be. And the that being very hyper vigilant about anyone possibly saying anything about their appearance. I mean, the worst thing you can say to someone with anorexia if they've gained a bit of weight is saying you're looking well. You know, you just cannot comment directly on their appearance, because they will immediately interpret that, oh my God, I must have put on weight. That's it. I'm not going to eat for the next 3 days. And it can be, you know, that trigger sensitive, unfortunately. And, you know, the end stage of all this, obviously, is they become very suicidal and will start acting out. So that self-harming behaviour that is so prevalent now in adolescence, and we saw so much more of during COVID as well. So, you know, this is where this sort of tsunami of mental illness has been unleashed with COVID, and now we're seeing it, the anxiety around going back out into the community as well. You know, I don't know if all of you have been seeing this, but it was bad enough when everyone was in lockdown, particularly in Greater Melbourne area. But now, as you know, everything's opening up again, people are getting incredibly worried about being out in the world again. The behavioural warning signs. This dieting, oh, I'm not going to eat that now, I'm not going to have that, I can't have pasta, I can't have carbs, blah, blah, blah. This isn't an absolute red flag at all, but if you've got particularly a kid or an early teen who suddenly decides they want to go vegetarian or in fact become vegan, that's absolutely fine if they're doing it for ethical reasons. But, you know, if it's suddenly just come out of the blue and they can't really justify it if you know, you ask them a bit more about it, it's something, I guess, to think, well, all right, what's this about? It might be an indicator that something's going on. The evidence of binge eating, that can be where, you know, there's been suddenly quite a big gain in weight. The evidence of vomiting or laxing of youth, we've spoken about that, the callus. The other thing can be the recurrent dehydration, or in fact, if you happen to be checking someone out because they're complaining of fatigue and you discover they've got electrolyte disturbance, that can, or renal impairment already, that can actually be a sign that they're actually abusing laxatives. This whole compulsive exercise, where if they can't do their workout, they become incredibly distressed. So we've got, you know, people that, you know, might go to the gym on a regular basis. And, you know, I found during lockdown when the gyms were shut, there's all these people were unravelling because they couldn't go to the gym. And all of a sudden it became very evident they actually were, you know, had major body image issues. And if they couldn't exercise, it all was falling apart for them. The changing in clothing style, we often see kids particularly will suddenly start wearing really baggy clothes, seeking out baggy clothes to try and mask the fact that they're actually losing a lot of weight. We've spoken about change in school or work performance. Rituals around food, you know, you sometimes have people that, you know, they'll only eat a certain colour of food, or they can't possibly eat things that are mixed up together like with casserole, or they might sit there and take an enormous amount of time to actually finish their meal. And I often said to parents, you know, well, you know, are your kids chasing the pea around the plate? That they might be, you know, or hiding food, you know, if there's the dog or the cat or the pot plants getting the food stashed. So all these sorts of things that, you know, if a family come in and report those sorts of behaviours, they're actually pretty strong indicators that things are going awry. And I've spoken to the changes in food preferences already. Going on, we've got the social withdrawing. So, you know, not wanting to eat with the family, not wanting to go out. Hopping on the scales repeatedly, eating very slowly, all of a sudden wanting to be hands-on and wanting to prep all their own food. That's often quite a stark thing out of the blue with teenagers who, you know, just assume everything's going to be done for them, and all of a sudden they have this incredible interest in looking up cookbooks and wanting to make all their own food, and then, oh, I've already eaten, I went to my friend's house and had something over there, or I've eaten on the way home, and so making excuses so they don't have to eat with the family. All right, so what's our job as the GP? Well, number one is to establish rapport. So if they're, you know, and this obviously varies if they're a patient that you've known for a long time already in the country town you happen to work in, or the suburb that, you know, that you've worked in for a while, or in fact, if it's a new patient. And so, I mean, you're not going to be able to cover everything at the first appointment, but I guess just trying to get that dialogue happening and developing some trust is really key to try and facilitate people opening up. Then, if you really have some concerns, I guess after you've done some screening, which we'll talk to very soon, we then need to work out a risk assessment, which we do with any sort of potentially serious medical condition. So doing some basic OBS, which we'll go through in more detail, and then assessing their psychological state, assess whether they're safe, I guess look to excluding any other underlying illnesses. So look, they might have celiac disease and that's why they feel sick when they eat. You know, they might have PCOS, they might have a myriad of things, but you do that, but also with a view to it's excluding that's the cause in order to make the diagnosis. And then working out over the course of usually 2 or 3 or sometimes more appointments, where's the best place to send this patient for assistance. And then knowing your local treating teams, so you can then coordinate a care team and be an active person in that care team and making sure that everyone's on the same page. And then the key role for us in general practice is doing the ongoing monitoring of the medical state and also the psychological state. That's for people that are being managed in the community. So in that initial appointment, I know you're probably all feeling like this is all too hard, but trust me, it isn't. It isn't. And we're going to give you the skills to be able to handle this very competently. All right, so what sort of things do we need to consider? So establishing the urgency of treatment. If someone's frankly suicidal, or you take their OBS and their heart rate is ridiculously low, or you do a random finger prick glucose assessment and they're really hypoglycemic, well then obviously they probably need to be sent to the local emergency department for medical stabilisation. I've spoken briefly about, is it someone you know very well or is it a new patient? And then the presenting issue. Now, is it they're coming in because they're worried that they're overweight and they're wanting some help to lose weight? And that allows you to start a conversation about, finding out what they eat and how often and so forth. Or is it more physical? Working out what tests are appropriate and doing some baseline OBS, so lying and standing blood pressure and heart rate and a height and hopefully a weight if they'll let you. And that can be a bit of a tricky situation, but I'll talk to you more a little bit about how to maybe achieve that. And also bearing in mind that you're not going to be able to cover everything in just one appointment, because usually people only book a 15-minute appointment and there's only so much we can do in that time. So doing an assessment, and those of you who've been working in general practice for a while, particularly if you've done much work with young people, are probably familiar with one of the tools that we often use in these sort of scenarios. It's the HEADS assessment, and basically it gives a fantastic overview of where that person is sitting. Now, it was designed for use with adolescents, but you can use it with anyone really. And under E, you can actually also include eating there and get a bit of an idea about, are you a vegetarian? Have you become vegan? Is finding certain things that don't agree with you, or you prefer not to eat? So it's very much just sort of feeling out where they're at, what their home life's like, what their stress levels are like. Are they feeling safe? Are they feeling suicidal? What's their mood like? All that sort of thing. So it's a nice little gentle way of working through some of the tick boxes for things that could actually be predisposing someone for an eating disorder. Okay, now the SCOFF, I don't know how many of you are aware of this, but it's a really handy little tool that I use a lot. Certainly I incorporate it in if I'm doing a mental health plan for somebody, if I'm, seeing one of my women who are coming in for some pre-pregnancy counselling. If they're coming in, they're already pregnant, I do it as part of that antenatal workup, because it's a very simple little tool that's been shown to have a pretty high pickup rate of someone who might be at risk of an eating disorder. So basically, as you can see there, SCOFF, are you making yourself sick because you feel uncomfortably full? Do you worry you've lost control? have you recently lost more than 1 stone, or it's, you know, around 6.5 kilos over 3 months? Do you think see yourself as fat when others say you're too thin? And would you say food dominates your life? So it's a really quick and easy thing to administer, and any score over 2, if they answer yes to 2 or more of those, then you need to think, okay, maybe there's something going on here. Now, if you want to also add in a couple of other little questions that actually are very specific and sensitive for bulimia nervosa, as you can see there, are you satisfied with your eating patterns, and do you ever eat in secret? So it's effectively 7 questions. And so if they answer yes, then it's worth screening further. And, you know, we'll have all of this in the resources for you as well. So as hopefully all of you are aware, in November 2019, the Health Minister, Greg Hunt, announced this raft of new item numbers for use by Medicare, or most of them for general practice actually, to perform assessments to see if people are eligible for the super duper eating disorder plan. And with that, in order to do an eating disorder plan, we have to assess if someone's eligible for it. And the key way to do that is Medicare decided that we have to use a tool called the EDEQ. And as Rebecca said at the intro, at the start, if you look at the Eating Disorders website, we've got lots and lots of information there about how to do an eating disorder plan and links to the EDEQ. And it's quite a comprehensive assessment. And I often will I'll direct patients to it and get them to do it at home at their leisure. And because it's about, how many questions is it, Rebecca? It's about 30 odd. It's quite long.
Yeah.
It's about 7 or 8 pages. So it's not something you'd necessarily be doing in the consulting room with the patient there. EDV also have the capacity that patients can ring up and do it with Shannon, who's the eating disorder nurse, and she will actually save the document and then email it to your clinic. You know, just get the patient to let them know which clinic you work at and your name, because some of the questions can be a bit triggering, and so it's sometimes nice if people feel that they might get distressed doing it themselves at home, even though they can save it as they go and do it over, you know, however many days they need to take to do it. It's sometimes nice to actually have someone on the other end of the phone. I have trained up our practice nurses actually to do it as well. So that's something that you might want to do if you are very, you know, time strapped or time poor. And yes, so this is the online link for the questionnaire, which is on the Inside Out Institute, which is sort of the peak research body for eating disorders that has gotten a bucket load of funding off the federal government to develop all sorts of resources and also do research. So the eating disorder management plan now, which hopefully all of you have at least had a look at, if not already performed, is opens up a lot more support for people with eating disorders. Basically, they get, it can either be performed by a GP or a psychiatrist or a paediatrician. So in my experience, it's usually left up to the GP to do. The psychiatrist may say, I think this patient has an eating disorder, go back to your GP and they can do the plan. So with that, you have to assess their eligibility, and that's where the EDEQ comes in. And there is a template that you can actually incorporate into your medical software, which is certainly a useful thing to do. And either for medical director or best practice, I'm not quite sure whether it integrates with the other things, but you can usually just import it into your letter writer anyway. And that just makes life a hell of a lot easier. And it's basically a mental health plan embedded within a very much more comprehensive plan with lots more specific questions about the pattern of eating that the individual is undertaking. Okay, next slide. So going on to the eating disorder item numbers, basically the eating disorder plan is they've got different item numbers for however long it takes you to do. So if you've got capacity and you can spare, you know, a 45-minute appointment and do the EDEQ with the patient, then you can bill accordingly for that. There are longer time-based item numbers like, you know, mental health plans and our standard GP consults. And basically, if a patient is found to be eligible on their EDEQ score, then it automatically gives them access to 20 subsidised sessions with a dietitian, and you don't need to do any reviews. It's just straight up 20 if they feel they need it, plus also up to 40 sessions with a mental health clinician who ideally has expertise in managing people with eating disorders, and that's over a 12-month period. So it's effectively 4 times as many sessions that you could access through either a care plan for dietetics or indeed a mental health plan for psychological support. So that sort of really indicates that even the government has recognised that people with eating disorders need far more support than was available to them up until these new item numbers were developed. So they basically get the same rebate as they would with those other enhanced primary care plans, and the medical practitioner has to trigger the assessment, and there are key points along the way where they have to do reviews. And so basically it's every 10 sessions you need to review the patient, and there are item numbers like review of an eating disorder plan, the same as a review of a mental health care plan, or review of a EPC. Okay, so go on to the next slide.
We've probably covered that one, Jenny. I think we'll move on.
Yeah, okay, good. All right, so we've got in the pack of information we're going to give you, we've developed some cheat sheets for you just to help you navigate the item numbers and also indicate at which point you need to the review. And the key thing there is that after 10 sessions, the therapist contacts you like they usually do with mental health plans, and the patient, if they still need more support, they come back and see you and you do the review, which is basically how you're going, do you need some more? You don't have to do the EDEQ again. It's basically just a sign off, yes, I think you benefit from having some more sessions. Then they can get another 10. Now, at the 20 session mark, there's the need for either a paediatrician for kids or teenagers or a consultant psychiatrist to review to unlock the next lot of sessions. So depending on where your practice is and what the waiting times are for consultant psychiatrists and paediatricians, if they haven't already got a psych or a ped, you might need to be proactive and actually action a referral early on in the piece, because particularly now after COVID, the wait times, particularly in our neck of the woods, have blown right out. So I tend to action that referral early, and then look, if they don't need more than 20 sessions, fantastic. You can always say thanks, but no thanks. But if you wait until they've already had 15 or 16 sessions and then put that referral in, they might then be left high and dry for quite some months waiting for that review before they can continue on with their therapists. So that's just a little tip there. The NEDC, which is the National Eating Disorder Collaboration, which is another sort of peak body that is working with the health department in developing all sorts of guidelines, have some really good resources as well, and that link will be in the pack also.
And Jenny, we've just hit 8 o'clock, so maybe we just do these two. Well, we're right on 8, so I think that Jade will probably be coming back in.
Sure.
Yes. So, okay. But everyone will get all of this information with the PDF of the slides.
Yep.
So
yeah, look, there's an awful lot of information in here that we normally take much longer to present all of this and have interaction. So apologies for my speaking so quickly, but we're trying to sort of get all the salient points across. So basically with this slide, you're eligible with your EDEQ if it's over 3, and then you fulfill a few other criteria, and there's the templates have you just tick the box which criteria they're filling. And if they've got anorexia or have been having community management and they're not getting any better, or they've been hospitalised for their eating disorder in the previous 12 months, they also are automatically eligible. Okay.
I do have a question. Can you
Yes.
please run us through interpretation of ED-EQ? What is the eligibility requirement for ED plan? That came in 10 minutes ago.
Okay. So the EDEQ is the assessment tool that you use, and that is on that link that we're going to give you. It's basically a comprehensive assessment quiz that the patient does about what their thoughts and behaviours have been in the previous 28 days, how frequently certain activities or thoughts have been affecting them. And the online assessment actually generates a report as part of what it does and gives you a score across a range of criteria. So there'll be, there's a global score, and they have to have a global score greater than 3 to be deemed eligible. But within that, there's a breakdown. So it's, preoccupation with body image, restrictive behaviours, and so on and so forth. So when they do their quiz, at the end, it generates a report that has a bar graph, and also will tell you that, your answers indicate that you have an eating disorder, and we recommend that you, seek medical assistance. So the patient will do that. And what I do in my practice is, if they're doing it at home, I get them to save the PDF and to email it into me, and they have already got a double appointment booked to come back to do the eating disorder plan. And if they don't score enough or aren't eligible, we still do a mental health plan anyway, and also talk about getting a care plan done, because then they can still access support through the mental health plan and the care plan for dietetics, but they just don't get the degree of support they would if they were eligible for the eating disorder plan. So does that answer your question?
Just to follow up from that question from the same person, i.e., how do you score it? There's many questions with answers each 1 to 6.
Yes, so it's if you get them to just tick the box, which is one of the forms you find if you Google it, it's an incredibly complicated scoring process. So it's best to do the online one, and the algorithm, the online link actually automatically does it for you. Because if you just get them to tick the box like you would doing a K10 or DAS, and you just add up the score and then, whatever their score is, it's very different with the EDEQ. It's actually quite complicated, and there's many different aspects to it. So none of us have the capacity to do that. We don't have the time, and we haven't got the training. But if you use that link, and often with the template, when you download it, the actual link is embedded in the template. So sometimes if I don't have a frantic day, which doesn't happen often, and I've got someone who really is not very tech savvy, I will actually sit and do it with them. But it generates the score automatically. You don't have to do anything about adding up the score. Does that clarify things?
Yes, thank you very much. So
okay.
there is no more questions at this stage, but if anyone's got any questions, still type them in the questions box, because we will get them collated, and Jenny and Rebecca will answer these for you by email. So thank you to Jennifer and Rebecca, and we will go straight on to Holly from Bowen Health, who'll give us a update. Thanks, Holly.
Thank you. Hopefully, here we go. Is that working?
Yes, we can hear you, Holly.
Okay, I'm just trying to share my, I'm sharing my webcam, but it's not working. You can hear me, but you can't see me. Is that right?
I've just tried to switch the presenter controls over to you. So if you just hit that button to share my screen, that might work.
Okay, no worries. I can just see Jenny.
I'll send you through another webcam request.
There we go.
Perfect, well done.
Beautiful. That's worked. Oh.
It's just turned off again.
Oh. There we go.
Great, go for it.
Okay. Thank you. Thank you all so much for coming tonight. And can I just say, it is a lot of information to digest, but you know, the majority of the referrals that we get, so my name's Holly Laver, I'm the manager of the Barwon Health Eating Disorder Service. The majority of the referrals that we get from GPs and other health professionals are fantastic, and they're really appropriate. So know that many of you are on the right track, and that services like the Barwon Health Eating Disorder Service and EDV and so many other resources are out there to help you as well. So just to give a bit of an update for kind of Barwon Health and the Barwon region. So Barwon Health is a public health, obviously, public hospital part-time specialist service that provides assessment and treatment for young people, so those aged 0 to 25 years experiencing an eating disorder. That's all the eating disorders that have been covered in the presentation, including binge eating disorder and ARFID, although obviously the kind of the severity of those disorders are quite high by the time they're coming to a tertiary mental health service. So our service is based, co-located with Headspace in Geelong, so right in the centre of town in Yarra Street. What we tend to do is people refer through child and youth triage. So most of you would kind of use ReferralNet and probably through kind of the health pathways that was referred to at the beginning, ReferralNet, or make a phone call to child and youth triage through Barwon Health Mental Health Services, give all your information. That gets sent then to our team if it's deemed kind of appropriate to come through for us and isn't kind of better served, the young person and their family aren't better serviced by a private practitioner. We then have a talk about it in our team meeting and kind of triage accordingly, and then invite the young person and their family in for an assessment. So the team's made up of psychologists and occupational therapists, a dietitian, psychiatrist and psychiatry registrar. It's 3 days a week, Mondays, Tuesdays and Thursdays. So we've had a bit of an expansion of the team, which has been fantastic. Over the last couple of years, particularly, or 2019 to 2020, even pre-COVID, we'd had an increase of 35% in referrals. So just to kind of give you kind of an example. So last year was another increase on top of that of another 30%, which obviously COVID, as Jenny mentioned, has been really difficult for people with eating disorders, particularly young people. But essentially what that means is that we've had a huge number of referrals into the service. So it's the waiting times have been quite challenging. And we probably, last year we had, I think, 155 referrals to the service, and we operate 3 days a week. You know, we've got a very small team, and we're obviously seeing the most unwell in the region. So if you're thinking about when do I refer to, say, a tertiary mental health service, so it's when the severity is quite high and the acuity and the complexity, and you know, you're ticking kind of all those boxes through meeting all those criteria, or nearly meeting all the criteria. Ideally, we'd like to be able to get back to doing a lot more early intervention work. Certainly we do early in life intervention, but we'd like to do early in illness. But the capacity, the demand is just so high at the moment that it really is the most unwell in the region. If somebody's needing an admission, if they're medically unstable and they're meeting that criteria, which are your usual criteria around, you know, heart rate and all the postural indicators that that Jenny was talking about, then the admission for our under 18s is to the paediatric ward, and we have a shared kind of protocol guideline with them, very close working relationship with the paediatric ward, and we jump on board, would see the young person if they haven't already been seen, and kind of commence treatment within the hospital to then hopefully allow for a smooth transition to outpatient. If they're over 18, they go to our endocrinology ward, and this is all based at University Hospital Geelong, again under the same protocol, which is they're given meal support, they're stabilised medically. Ideally, they're very brief admissions. We always say to people, you know, you get well at home, you get medically stable in here, and then you get well at home. Treatments that we offer at the service are all the ones that Jenny had listed that will be presumably in your packs, but we do for under 18s. Our go-to, the gold standard, is family-based treatment for anorexia nervosa and bulimia nervosa. We offer adolescent-focused therapy, CBTE. We also offer cognitive analytic therapy for kind of a bit more relationally analytic kind of based therapy, as well as kind of looking at lots and lots of motivational work, engagement. We have our dietitians obviously doing our nutritional support. So I've already mentioned our referrals are made through child and youth triage. Through that referral process, if it's not a GP making the referral or a paediatrician, we would direct them to have, or they would be directed to have a medical review, just so that we know as a team and can kind of triage accordingly how urgent people are based on their physical health, but also their mental health needs, and just to get a sense that they're actually okay to walk through our door and they don't need to go to the emergency department instead. So there are no public eating disorder inpatient beds in Geelong. Russell Golden's going to talk about the private ones shortly. So we very much have, as I said, strong working relationships with our medical wards. If we really think it's indicated, we refer over 18s to John Cade unit, John Cade level 2 up at Royal Melbourne Hospital, but that's a very limited capacity. I think it's 8 beds for kind of the regional state area. So it's very difficult to admit people, and it's very hard for people to uproot and go to Melbourne as well. So where possible, yeah, we see people down here. In terms of, so our youth is 0 to 25 years. For people over the age of 26, they're still referred into the service via child and youth triage, but then they're seen by the community mental health adult teams. And their capacity is kind of varied. So but very much if you're thinking this person has a serious eating disorder, they live in the Barwon region, I would be absolutely referring them into Barwon Health. My team can do a lot of consulting, and that's certainly what I do or offer our doctors to review as well. But they're probably less kind of structured in the treatments that they provide, and there's a lot more higher comorbidities in that older age range. And probably what a lot of you are coming to know at the moment is private sector is very long waiting times, so people are getting sicker. And they're needing services like tertiary services like Barwon Health Eating Disorder Service more and more, which has put incredible strain on the system, and certainly the Royal Commission into Mental Health shone another light on things that we already knew, that you know, the service demand has far exceeded the capacity. So that's certainly where we're at, but if people are seen in terms of urgency, so we will see people if they're very unwell as soon as we can, and with a few more staff on board at the service now, hopefully that will bring the waiting times down too. So that's probably my update. I don't know if Jade's still there in the background. If anybody has any questions, obviously can pop those in. Otherwise, Russell can give his.
Right.
Thanks, Holly. We'll go directly to Russell. Thanks, Russell.
Thank you. I just want to make sure that you can hear and see me. There we go. And yeah, great. And Jade, you can drive some slides if we need to. Thank you. I'd just like to acknowledge actually my original training, which was through EDS in Barwon, and also the incredible help that EDV has given to in terms of knowledge and training to practitioners around Victoria. So very grateful. My thanks to Jenny, Rebecca and Holly. I'd like to refer you all to the handout section and the download documents that you have. There are 3 main ones that really explain the referral process to the Geelong Clinic. You'll have a instructions to GP letter, which stipulates the requirements, which is a referral letter, ECG, biometrics and physical investigations. We also have a physical assessment pro forma. You can get this all later on as well, which again has biometrics, vitals, blood investigations and some description of eating disorder behaviours. And lastly, there's an eating disorders information pack, which is downloadable there that can be shared with clients. In terms of the admission process itself, the key fax number is 52400 799. Subsequent to the referral letter, which is addressed to eating disorders program at the Geelong Clinic. And we then look at the physical assessment, and then subsequently we provide a appointment time either by phone or in person to the client. And then this is taken through an intake process, a team meeting, both in Peter O'Keefe's Learn to Eat at Peace program and my Proactive Recovery Enhancement program, and then to determine which program suits the needs of the client. And obviously, if the client requests a specific program, we do our best to accommodate there. The waiting times vary. As Holly said, there's an absolute excess of demand and undersupply, both in public and actually in private systems as well. It ranges from, I'd say, probably a mean of 5 to 6 weeks. It can be more at times. We're hoping to expand in the future. The LEAP program is an 8-bed 40-day program. My program is a 5-bed 40-day program, but with expansion in the clinic here, we're hoping to have more beds available. It's a real problem at the moment. It hasn't been solved, unfortunately. Just in terms of some of the a bit of the flavour of the inpatient program and what's involved. The LEAP program, as I said before, was Peter O'Keefe's program. It's been established for over 10 years. It's really a mark of excellence for eating disorders in the Geelong area. It's 8-bed 40-day program. It's catered to people in the early stages of their recovery. So people that clients that need to learn to eat at peace, learn to understand what adequacy is in the volume of their food, how to eat with enough variety, and it is at that basic level. My program, Proactive Recovery Enhancement Program, caters also to that level in terms of acuity, but caters also to those that have been stuck for a long, long time. And what we seek to do in my program specifically is to integrate skills consolidated in the inpatient program with real life skills. We found often that clients going through inpatient programs did quite well as an inpatient, but soon relapsed as soon as they left. And so we look at relapse signature, we look at structuring a program for them outside as soon as they discharge, and we begin that on day one. And we include also specific life skills like shopping, cooking, budgeting, and basic nutritional literacy, as well as looking in depth at co-formulating with them. So looking at the etiology, biopsychosocial skill etiology, as well as looking towards filling in a meaningful life, not just recovery in terms of normal eating, but looking specifically at the one question of what is left for you outside of an eating disorder and exploring that together. I might, Jade, have you guide us all to the timetable slide, just to give people a sense of what's involved. There we go. I'll try to look there. So the main focus, everybody, if you have a look, you'll see again our philosophy, which is inclusive of biopsychosocial and spiritual approaches. There's a main ward round on Tuesday in which clients will feed back both what's worked for them and what hasn't worked for them in the week preceding. Also, what are the obstacles remaining to their management, and we try to accommodate as much as possible. Both programs that I've just mentioned incorporate the eating disorder program philosophy, which is based on trust, dignity, individual treatment, and is consumer driven. So we are very, very respectful of consumer feedback. My program is largely driven actually by the advice of a consumer consultant, and it was on this basis that my program PREP was originally devised, with lots of consultation with consumer consultants and people with lived experiences. Jade, I'll just, we'll stay on that slide actually. You'll see also that there is therapeutic free time at the end of the week. And what we try to do there is, again, to allow clients to access a greater novelty of experience, so to allow them to start to fill in those gaps that have gone missing with the eating disorder, which puts their life on pause. So to start to do something novel, go to Gauze, do some putt-putt or mini golf, start to live their lives. Leave is specifically designed as well around practicing inpatient skills, and to see whether clients can begin to order out for themselves. If you focus just quickly on the dietitians group, you'll see that what we've incorporated in this program, probably for the first time as comprehensively as we have in an eating disorder program, is what we call shop and cooks. So we get clients to go out to learn to shop at supermarkets without getting stuck with calorie counting, to also learn to budget, to come back and to prepare that food, and I benefit from that, and to share that food and cook it and prepare for one another. So they actually get to sense and feel what a normal plate of food feels like. And as they progress through the program, they begin to expand on their repertoire of meals, and they have a specific dietitian formulation day where they get greater and greater variety and they learn nutritional literacy. There's also a consumer-driven group. Jane, I might get you to go to the formulation sheet, because I think that's probably what we'll have time for. Okay, so if we have a look at the formulation sheet, we can look at some of the etiological factors, biopsychosocial, and those are the why questions, and that is where we start to develop insight and to practice the co-formulation of why this occurred in the first place. It's really important that after we do that, however, we move from the why questions to the what now questions, and to start to establish strategies for relapse prevention. And if you go on to the next slide, Jade, great. We now then begin to look at future focus and orientation in regards to what they want for their life in terms of health, relationships. You'll find over there all the components of a worthwhile life, a life worth living, and that's what we focus on as well. So those are the main core components. I'm sorry, I sound like I'm speed talking. We've got such little time and so much to speak about. And the Geelong Clinic then will treat people across a range of diagnoses. It's transdiagnostic. We'll use evidence-based modalities already described. There's also this intense co-formulating and in-depth, as you see in the formulation sheet there, processes. We're establishing now a outpatient group, which is very exciting, based on what's called a temperament-focused therapy with supports. It's a new modality from the States, and that's coming up soon. It's starting in April, and it also incorporates an embodiment practice as well. We begin to allow clients to experience what it's like to be in their body. And again, that's part of our foundational approach here, is return to the body, not absence from the body. I think that's probably all we have time for. I'm very, very happy to respond to questions or to respond to emails.
Thanks, Russell.
My pleasure.
There are no questions at this stage, but please pop them in the question box if you have any, and we can pass them on to the speakers. Thank you to all our speakers tonight. Fantastic presentations from everyone. Don't forget your evaluation. Fill out the topics on that evaluation that you want for the remainder of the year. A couple of meetings coming up. We've got our sexual health webinar on a syphilis update on 22nd of April. 28th of April, we have our obstetric emergencies. That'll count towards your Barwon Health pregnancy care points. So if you want to come along to that one. Just a quick rundown, we've got our 29th and 30th of May, our primary care refresher, which is online. It was previously known as our GP refresher. The title is Partners in Prevention this year, and we're doing a GP stream and primary care stream. We've got some really great topics on that. Chronic disease, cardiovascular, mental health, food and mood, strategies for prevention of opioid problems, transgender health, ADHD, trauma-informed care, finishing off with a panel discussion on the topic of partners in prevention, building bridges, and our primary care stream for allied health and nursing and practice managers. We've got allied health and nursing outreach education, advanced care plan, child life therapy, business management, sustainability post-COVID, nurse-led clinics, employment issues. So it's a fantastic program, really good speakers. Keynote speaker is Professor Michael Kidd, and we've got our opening address by the CEO, Rowena Clift. So I hope you can all join us for that. I will have more information on in the coming weeks. And if you go to our website, we're finalising the program at the moment, so that should be up shortly. Thank you everyone for attending tonight, and see you all at the next one. Bye.